All
Hi,
right.
good
So
evening, everyone.
wait. Not yet. I'll cue you in. In 5, 4, 3, 2, 1.
Okay, good evening, everyone. Welcome back. We didn't have a webinar last week, so we are happy to have a webinar here. We welcome Dr. NAIM. Maybe he would like to introduce himself. NAIM is actually my colleague in Beacon, but we have not actually met face to face, and I'm so glad he agreed to give this webinar. There is a small change in the title. Because we did X-ray last 2 weeks, spot diagnosis. So Naim is going to do MRI in stroke. But Naim, tell us more about yourself.
Hi, Assalamualaikum. Good evening, everybody. My name is Naim, as been mentioned by Dr. Petty, my very good colleague from Hospital Beacon. I am currently the consultant radiologist in Hospital Beacon. I'm doing general radiology and with special interest in interventional radiology. I'm just joining in, I think, around end of the last year. Before that, I was in the hospital, medical lecturer in Hospital Pengajar UPM. Now they are known as Hospital Sultan Abdul Aziz Shah, HSAS, I think.
They have a
Very
new
new
hospital,
hospital.
right? Where's the new
It's a
hospital?
really, it's behind Hospital Serdang. Now UPM now operate on their own hospital, no longer be with Serdang. Some partial clinicians still there, but most
Oh,
of
I
the clinicians are in the
see.
hospital.
Okay. Congratulations to UPM then. Okay, so without further ado, we start your talk.
Okay, thank you, Dr. Betty, for the kind
For me, better.
invitation.
How many times already?
Hang on, I just play the slide. Slideshow. Okay. All right. So first of all, I would like to say sorry because I need to change the topic due to some technical reason. And luckily, I just Dr. Betty told me that the lung topic and the all this I got also got same similar topic the last few presentations. So now I would like to bring you all to the advancements of radiology. I know that maybe not so related to your daily practice, but it's no harm to know the advancement of the radiological investigation. Kan, if you don't
Yes.
mind, I can mix with some Malay,
Oh yeah, of
Malay
course.
words so that it
Yes.
looks macam tak kompleks sangat. Kalau
No, we
if
are
all
very,
this
very laid back. We are
yeah,
very, not
so
so campur-campur pun tak apa.
yeah, this
Okay.
radiological jargons, kalau I use it too much, you all akan sangat boring. Sebab I mean, some of you maybe not involved in MRI at all. So let's start with the make it very general. So let's start with some introduction background because this is why I'm presenting this topic, because when I was in UPM, I actually am doing training in the neuro intervention. Okay, as you all know, radiologists, they are the general radiologists doing diagnostic. Maknanya, they will be reporting the CT scan, the MRI, the X-ray, the ultrasound, and there is a specialty in radiology called interventional radiology. These are the people who is a radiologist, but they do operation. What operation? Interventional operation. They do biopsy, they do drainage. If you work in the hospital yang big hospital government macam HKL, Sungai Buloh, Ipoh, Penang, JB, all these hospital they have this kind of service, interventional radiologists. Or some of you might work in some small center, but they have the radiologists can do interventional procedure. So these are interventional radiologists. So these people, they are doing operation on top of their reporting duty. So when I was in UPM, I was doing neuro interventional training, particularly on stroke. So I want to share with you the advancement of imaging in stroke, because so many people does not aware how advanced the imaging now in stroke, and how much we can prevent problem in stroke. Kita faham kalau kita stroke, patient ni kalau stroke basically dalam Malaysia ni kita kata macam dah dapat tali gantung lah. You are hanging lagi, you tunggu masa nak mati, you jadi sayur, you become vegetables, you waiting time, you can see people treating you bad but you cannot do anything. This is stroke understanding. But now actually stroke ni kita boleh prevent the debilitating outcome tu kalau kita act very early. So imaging play a very important role untuk people decide whether this stroke is preventable death or not. This is what we are doing in UPM, in Hospital Sultan Abdul Aziz Shah now, belakang Serdang. Bukan Hospital Serdang, belakang Hospital Serdang. A different building as big as Hospital Serdang. Okay, so I'm doing 2 years training of neurointervention there. I want to share with you all the advancement and what you can do if people have stroke. Recently, we have our minister, kan, Datuk Seri Salahuddin, who died of hemorrhagic stroke.
Very sad.
Hemorrhagic stroke.
So
Yeah,
sad.
and then what I heard is actually he had ruptured intracranial aneurysm. You know, so he had undetected aneurysm in the brain. Ada saudara bengkak dalam kepala dia. So dia ada high blood pressure, ruptured and then bleed. And then kita tak boleh salvage because too much bleed. So these are example of stroke, but these are all hemorrhagic stroke, means it's a stroke with bleed. But we are dealing, in my case, most of the time yang preventable are ischemic stroke, meaning stroke yang disebabkan oleh salur darah sumbat, hence tak ada oksigen dekat brain, the brain die. These are all most of the time preventable. I mean, we can give a better outcome for this kind of cases. Okay, tak apa, we go slow. If you have a question macam tak faham sangat or tinggi sangat, you let me know. I want people to try to dive in this. Then kita tahu dah kita kat mana, kan. Sometimes you sit in some hospital yang mungkin you know handle patient yang I know outpatient, mungkin tak involve sangat. This is the time that you can see all this. Alright, okay, so okay, ni macam biasalah disclosure, tak ada jual barang, tak ada apa. This is very genuine.
Yes.
Ikhlas, nak share with you all. Okay, Dr. Betty tak ada, Dr. Betty pun tak bayar apa, jangan risau. This is memang I suka je share with you all, don't worry.
Ada yang
Okay,
saya
so this is,
bagi cempedak lah, goreng cempedak kadang-kadang.
okay, I want to show you all. This is angio machine. Some of you might familiar with it, some of you mungkin tak berapa faham sangat. Ni angio machine. Angio machine ini, this is a biplane angio machine. You can have single plane also. So you can see my cursor or not?
Ya,
Ke
kan?
tak? Okay. So actually biplane, kalau angio machine ni is actually like an X-ray. So you all akan tembak X-ray, and then ni receiver dia. This is the receiver. So we shoot an X-ray, and then accepted by the receiver, then the image will come here. So it's like an X-ray, but it's a dynamic X-ray. Or kalau you all biasa lagi dengan perkataan machine fluoroscopy. This is a dynamic fluoroscopy. It's a very, I would say, advanced fluoroscopy machine. I think kalau government tu tak banyak hospital, ada hospital besar je yang ada HKL, Hospital Sungai Buloh, JB, Kelang tak ada, I think. Tak banyak. Penang yang besar-besar je ada lah. Okay. So this is angio machine that being used untuk interventional radiology buat prosedur. So dan I nak beritahu tu je lah, ni lah angio machine tu. Nanti I cerita tu. So bila in the advancement of stroke punya imaging, you actually can do a CT scan, a CT image by having a rotating angio plane ni. Machine ni kalau you rotate dia boleh buat macam gambar CT scan without sending the patient to CT scan.
Oh, I see.
Then orang akan tanya, why you want to do a CT scan like image in angio where you can send the patient to CT scan straight away, better image. Now you must understand, in stroke, every second is gold, is life. So if you transfer patient too much between some modalities, you are losing the time. The brain is keep dying. So that is why if you have one machine can do everything, imaging the brain and bring to angio for thrombectomy. Thrombectomy ni maksudnya kita masuk dalam salur darah dia, pergi dekat otak dia, tarik sumbat tu keluar, bagi ada balik darah. Tu thrombectomy. So people want to actually shorten the time between the onset of stroke. Maknanya kalau tiba-tiba dia jatuh tu, on that onset to the thrombectomy must be very very short. Baru the outcome very good. So sekarang ni masalah kita ialah patient stroke. Masa untuk sampai di hospital cukup lama. Itu baru sampai di kecemasan. Kan? Belum sebut pasal patient from the kecemasan, they have to bring into the requesting the investigation. Oh, nak minta CT scan, nak minta ni. Oh, ni tak urgent, esok lah buat. Kan? Itu dah berapa masa lagi tu. Lepas tu, when you come to CT scan, you nak prepare machine apa semua. So all those are actually, people are losing the brain cell during the stroke attack. So this is the problem. So whenever you can cut short the time for the procedure, they will want to cut short. So if you can do a CT scan in an angio setup and straight away decide for thrombectomy, then they want it to be like that. So that's why kita ada machine angio ni, dia boleh buat CT scan. Bila kita rotate, sistem tu boleh rotate pusing satu kepala tu, then we can have a CT brain in the angio machine. Kenapa kita kena buat CT brain kalau stroke? Sebab kita nak bezakan between hemorrhagic stroke and ischemic stroke. Hemorrhagic stroke basically gone case. You tak boleh buat apa-apa. You kena take out the clot je and pray that the bleed is not going to get bigger. But ischemic stroke, you can take out the clot and the blood can flow back to the brain. So that's why you need a CT scan at least to see whether it's a bleed or is a ischemic stroke. Okay? Kalau tak faham tanya. Okay. Alright, so I want to share with you is our experience in HP UPM in hospital UPM lah, easier way. Okay, so in hospital UPM, the first line imaging of stroke is MRI. Maksud dia kalau patient datang with stroke symptom, we will do MRI instead of CT scan. So I want to show you what MRI can help with the brain imaging for patient stroke. Ramai orang rasa kalau patient stroke nak cepat buat CT scan, buat MRI lambat. We have been doing for the past, I think until now, since I left pun, for the past 4 years, they will be doing MRI brain for stroke, and they have proven that there is no delay in terms of treatment, either using a CT or using an MRI. So we had one patient ni dia ada cancer NPC, dia ada cancer hidung, cancer kat hidung tu lah. So bila cancer kat hidung, dia underwent radioterapi. RT tu radioterapi lah. So dia tembak dekat area neck ni kan. Dia tembak radiation therapy. So 15 tahun yang lepas. So selepas 15 tahun menerima radiation therapy tu, tiba-tiba pada hari kejadian, he had the power on the left side macam slightly low. Dia punya rasa lemah kan. So if you have a one side lemah, my dear audience, if you have one side lemah, do not delay, please bring patient to the hospital, the nearest hospital. Stroke must be excluded. So dia ada jatuh sikit left ni, kemudian left side body dia lemah. So NIH score is the score that we use to stage the severity of the stroke. Basically, if you have 4 and above is considered, 6 and above is considered major lah. Okay, tak tahu score tu pun tak apa. I'm just telling you. So it was actually mild stroke. So vital sign is okay. So we do MRI brain. So we don't do CT scan. We do MRI brain. Okay. So MRI brain, the capability of MRI brain to detect a very early infarct, early stroke, early stroke in the brain is much more faster than the CT. This patient, kalau dia pergi ke hospital yang hanya pakai CT scan, they wouldn't see the stroke. This is the difference. Okay, dekat MRI dia ada satu sequence that we call DWI. Jangan tanya nama panjang dia, tak apa, faham je DWI dulu. DWI is the fastest sequence. The fastest imaging yang boleh detect the earliest stroke in the brain. So imagine we have been using a CT scan untuk tengok stroke, betul tak? Kalau tuan-tuan datang hospital dengan one-sided weakness ataupun neurological disorder, you will get a CT scan at least, if you are lucky enough. Sometimes boleh balik je kan. So you imagine if we can only see a stroke sign in the brain using a CT only after the earliest 24 hours. Maksudnya dah 1 hari baru tahu, stroke rupanya malam tadi. But MRI can detect as early as 1 to 2 hours. 1 hour maknanya kalau dia daripada datang tu bawa pergi hospital, mendaftar apa semua tu, we can already see ada stroke ke tak, and we can institute the right management as early as possible. Okay, so this patient dia ada stroke dekat what we call caudate nucleus lah, yang bright ni, caudate nucleus dia ada stroke. So we were finding why patient ada stroke. So bila kita buat MRI, this is MRA. magnetic resonance angiography. Okay, so mungkin gambar ni agak kompleks sikit, saya nak cerita, kena follow sikit saya. Okay, sepatutnya saudara ni, kalau you tengok I punya cursor ni, if you see my cursor ni, ada satu saudara tu hilang kat sini. Sepatutnya they have another big saudara that supply the brain. The main supply of the brain is ICA, internal carotid artery. Kalau you all tak ada internal carotid artery, one side of your brain gone. So dia punya right ICA ni, yang bulat ni, tak ada. Kalau you tengok ni, yang this one ni, belah kiri dia ni yang besar ni, these big vessels ni absent on the right, same side with the stroke that happened on the right side of the brain. So
this contrast is given through the vein.
No, this is not even contrasted. This is a plain MRI study. This is MRA. MRA does not use any contrast at all.
Oh, it doesn't need contrast.
Yes.
Oh my God.
So imagine.
I see. Amazing.
So without contrast, you can detect early stroke. You can even portray the vessels without giving contrast. So MRI. Very nice. So as for now, as much as I understand, only HPUPM doing MRI for stroke. So if you happen to be some of your relative, your friend, or you're the one that you know very near to HPUPM in Serdang, advise them skip all the hospital, go to UPM. This is my advice. There are still government hospital.
Very true, because we actually a lot of patients within 3 hours of their onset of stroke, we try to send to UPM because there is a team there, kan?
Yes. We have a standby neuro intervention team. We can do angio from the door to the angio maybe less than 1 hour. So we can open the closing vessels. We can open within that. So there are some centers you can do this early. UPM, UKM. And HKL Sungai Buloh, but this HKL Sungai Buloh, as you all know, hospital government that caters everything, you must expect some delay because they will screen the case, they will say this might not be this, it might be that, and they only do CT scan. Out of all this center, only UPM does MRI, only UPM. Okay, so I can tell you, if you have somebody have stroke symptom, skip all the hospital, go to UPM. They will be more than happy to accept you all because they only do stroke neuro case. They don't see cough and cold, they don't see this. So this team dedicatedly see only neuro angio case, neurovascular case. Okay, there will be some iklan. I'm no longer there, but they are still in contact with me and they are very good. Okay. So maybe Dr. Betty, one day we can have an angio machine in Beacon. We can do this, Dr. Betty.
I want an angio machine, okay?
No, please, we can do this.
No, okay. I don't even have NCT angio. Let's not talk about angio. Okay, let's go on.
Okay, now, okay, this is what we call, this is a cerebral blood flow. Okay, so the green color ni shows a very good perfusion of flow to the brain, and you can see on the right side, surprisingly, there is no flow on the right side of the brain. So we have stroke on the right side of the brain. We have a big vessels which is absent, supplied to the right brain, and there is a very minimal flow to the right brain. You can imagine the right brain is actually have a very low supply. And this is, Dr. Betty, this is a non-contrasted MRI.
This one I can understand, but this not the one MRA is amazing.
No, MRA, MRV, we don't use contrast at all. So that's why MRI has so many advantage over CT, so many, but it is understood as a complex investigation. It's understood that way. You can imagine within 5 minutes doing MRI, we can decide whether this patient should be thrombectomy or not. 5 minutes. We can decide, we can prepare the room, finish MRI, 20 minutes, straight we push angio, thrombectomy. Very fast. We done it before. I don't believe it initially, but we done it before. Okay, many cases. Not only one, many cases. Okay. All right. So diagnosis, as you all know, acute right caudate nucleus infarct. Match on flare means it's a quite mature infarct. It's more than 4 hours. If you have a flare sequence show something, means it's more than 4 hours. And if having said this, if you see this, because of such a big absence of the vessel yang besar tu tak nampak, brain dekat belah kanan dia tak ada flow, tapi dia punya stroke sikit je. So it means that it's a chronic changes, it is not acute changes. So the brain dia sebenarnya dah lama kurang supply sebelah kanan, but the dynamic of the brain, if you have a slowly kurang supply on the left brain will help you. The function of the right brain tu will be supplied by the left brain slowly by time. Tapi mungkin at that point of time ada episode of blood pressure low ke, dia tak makan ke, dia lemah ke, so the overall flow of body turun disebabkan belah kanan tu kurang supply, dan dia dapat stroke. Okay, so because of this patient masa tu, it is a we diagnose a chronic long segment, chronic stenosis, bukannya baru. We decided to start antiplatelet and we do angiogram the next day, and because we want to know what happened to the right brain punya supply vessels. Okay,
So the cutoff point for, let's say, an acute case where you do thrombectomy or thrombolysis, what is the cutoff point?
Okay, there are difference in thrombolysis and thrombectomy punya cutoff time. Thrombolysis, you bagi ubat cair darah through the vessel, so the blood, the body receive all over buat cair darah, so we hope it help the brain. Okay, so thrombolysis, the cut off window very short sebab there are some other side effect that they are worried. So usually they are taking 4 to 6 hours, maximum 6 hours according to the trial, 6 hours.
Okay, so in this case boleh buat tak?
Okay, sebab kalau kita kata dia adalah okay, then another criteria for thrombolysis pula, dia bukan hanya masa. Thrombolysis, you need a high NIHSS score. So usually you go more 6 and above. Sebab thrombolysis, the risk is very high. So kalau kalau the weakness does not affect.
Okay, so the benefit is not the benefit does not outweigh the risk, then there's no point to. Okay, okay, I understand now.
Tapi say I bagi tahu contohnya some mild, some macam satu disability. For example, dia tak boleh nak cakap sangat, dia jadi aphasic. Okay, and he's a lecturer. So those are the cases that we might still try to salvage the function of the speech because of kerjaya dia. We still give thrombolysis. The weightage tu agak sukar sikit. Kita kena banyak benda kita kena tengok. But thrombectomy according to the trial can go up to 24 hours. 24 hours. The longest we did masa I was in UPM was 12 hours. The patient come very bad stroke, 12 hours, we still do thrombectomy.
Still can see improvement.
Still, acute outcome not so good. We also worried that we have tried our best, but nampak. Tapi after 3 months, patient boleh naik basikal, and after 3 months, he sent us a video that he's singing. So, so we were glad. So because stroke is very dynamic, so you at the point of after you treat, you may feel that you tak bagus sangat, but kalau with the rehabilitation, enforcement, they might recover very well. I went to Hajj last month, Dr. Betty kan sebulan.
Oh, congratulations!
I had one of the peserta, still young. He was involved in the motor vehicle accident. He had a transected cord. He was paralyzed. He can't even control the bladder. He was told that he will not even have a child. Baru kahwin accident. Masa I jumpa dia, he walked very well. He was so active, tapi he was labelled as some disability. So I was wondering why you were labelled as this. And actually, I have a transected cord, but he was walking very well. So when you are dealing with neuro, it is very important not to give up early. You should not give up early. You must rehab. Somehow this nerve, somehow that people cannot understand, cannot really explain for now, it can cover the function of the motor if patient is still young and have a good recovery and rehabilitation plan. Okay? Okay. So the audience, remember, kalau do not give up on stroke patient, please. Kalau you give up with the stroke patient, the patient yang already stroke, they cannot do anything. So the support system is very important.
Yeah,
Please
sometimes
bring them to
being
the
a
right center.
GP, maybe if you see a patient with a stroke on a regular basis, just to give moral support and encouragement is also a way to improve the patient moral.
Yeah,
Yes,
yeah,
I think as a
agree.
GP, yeah, don't only think about the blood pressure, which is important, of course, but the progress of the patient, motivation, positivity is also important.
And I tell you, when I went in stroke team, if you are talking this about apart from patient well-being, maybe some doctors are not seeing the bigger picture. I tell you, the business of rehabilitation is
Yeah.
so big now. If you don't believe me, you can go to Cyberjaya. There is a rehabilitation called Dihan from Korea. It's a rehab center, very, very, I mean, like very advanced rehab center. And we have this, my friend developed a company, Sama-Sama Jaga, providing nurse to the home on the rehab center. Rehabilitation has been, I mean, good for the patient, but also good for the business if that's what you're talking about win-win situation kan. Sometimes doktor rasa buat apa patient tak ada harapan ni, kita jaga ni bukannya untung, but if you
Yes.
are seeing on that side, it's really now advanced, and we are moving towards old age country kan, ramai orang tua.
Yes.
So these are the thing you have to look into lah. Okay,
Okay.
so okay, I go this then. So okay, this patient dramatically, when we plan for angiogram the next day, suddenly the weakness worsening. So weakness worsening for the score from 2 become 12. This is nice case lah to share with you all. So this is the progress of the stroke. It can happen. You imagine if your patient is well, you discharge patient home. 3 hours later, patient become like this. So patient has to come again to the hospital. So luckily patient is still we are meeting the patient. So we repeat MRI. Now you see the bigger area of the brain is actually involved, and now this is why the weakness become worsen. And you can see in this flare mismatch yang I cakap tadi, kalau dia match means ada kat sini, ada dekat sini, means a mature infarct. But if you see in DWI but you don't see in flare, maksudnya dia baru jadi. Memang baru jadilah, 3 hours baru jadi dekat depan mata kita orang. So this is a very, very, very super acute infarct, and MRI has detected it. You send for CT, you're not going to see anything. Okay, so very big area, and then we thrombolize the patient, Dr. Betty. Now we are giving thrombolysis. Okay,
So you're doing
so
both.
this is both, because initially he doesn't fit into our criteria, so we don't give.
Yes.
But because of worsening this, then we give thrombolysis. And this patient have thrombolysis and thrombectomy.
Yes.
Then I show you, maybe I can straight away go to this. Okay, you see here. Okay, so this is an angiogram picture. Angiogram picture ni maksud dia daripada machine angio tu you buat.
Yes.
You can subscribe, potong gambar, you can only see the vessels, but kita nak fokus dekat vessel. So you see, this is the ICA yang hilang tadi. Dalam MRA tadi yang tunjukkan hilang. This is in dalam angio. And sepatutnya dia supply, you nampak the yellow color vessel ni, sepatutnya ada straight jalan supply this area. This is MCA. This is medial cerebral artery. Sepatutnya is a branch of internal carotid artery.
So it's
internal carotid artery tak ada.
totally occluded.
And the medial cerebral artery receives supply from the external carotid artery. This is the beauty what God have created the brain. Brain has the ability to gain the supply from a vessels that originally does not supply them.
It's called collateral.
Collateral, yes. This is called collateral.
Not only the brain,
this is a
even the coronary.
Yeah, this important organ in our body that can prevent from death, like
in
brain.
any supply, even in peripheral vascular also we will see collateral.
It's just in brain they can develop within seconds.
Yes.
That's very Apa nak? Very good. Okay. So now we have no big highway. So you only have small highway going into this. That is why when the patient has the stroke is worsening. When this highway, you bayang jalan tu makin jam, the flow makin turun, then the patient the stroke become bigger. So the anterior cerebral artery also occluded. Okay. So kita pun put in stent retriever. What we bring in some what we call catcher ataupun penangkap ataupun retriever lah. Retriever kita masuk dekat situ. Kita nak try buka salur darah tu supaya jalan besar ni, highway plus ni dia ada semula. Dia ada semula. Kalau tidak, dia tertutup kan. We must help the brain. Kalau dia stay on with this kind of supply, the brain will die. So we must help the brain. So bila kita masukkan, kita buka, kita berjaya buka. You see this ICA? You see this?
Oh,
This is originally tak ada. Walaupun it's not as big as normal, but we establish the flow back. You see?
yes.
So ini tadi tak ada. It wasn't there before. So we have actually some
You
called
guna
recanalize.
via apa?
This is-
0.035 or 0.0?
Oh no, 0.0, 0.18, 1418. 1418.
Same like our chorus lah, 1014.
Lebih kurang sama. Sometimes we use your catheter also. Your catheter is more stiff. So kalau a very acute angle carotid tu, memang kita pakai apa dia, Prof Sok pakai J something. something.
JR4.
JL. I pernah buat dekat Sedang sekali dengan dia lah. So, okay. So, you see, after that when we repeat MRI, you can see these big vessels. Wasn't there before? This one.
But is
It
there
wasn't
still
there
a stenosis there?
Yes, so there is a stenosis at the proximal.
Where the
ICA.
occlusion was?
Yes. So because this patient received radiotherapy, so this is a radiation vasculopathy.
Oh,
So the stenosis has created in a very long time and slowly occluded the ICA. So that is why the
so
brain.
can open,
So the brain has a sustainable time to develop some good collaterals. That's why he has no symptom for very long time, but some event actually aggravated the event. Some event aggravated the accident. Okay. So this is the beauty. I hope the audience boleh follow lah. Kalau tak
Don't
boleh follow,
worry,
bagi tahu.
Okay.
So now second case. Okay, second case. Another case when 59-year-old dengan history of NPC juga, and then ada radiotherapy, but this one done on the same year. And then suddenly develop expressive dysphasia. Expressive dysphasia means dia tak boleh cakap. Kita cakap dengan dia faham, tapi tak boleh cakap. Dia macam nak cakap keluar benda lain. So NIHS score yang I mention tadi now is 6. 6 is considered major. Besar lah. Consider they don't call it major, they call it big, macam major stroke lah, bukan minor. Okay, so again we do MRI macam I tunjuk tadi. We do MRI, show some small stroke. I bet you do CT memang takkan nampak lah. And then nampak tak match in the flare, so very new stroke, small. And you can see this time both ICA tak ada. Both highway kat ni tak ada supply brain. So the brain is actually having supply from the posterior circulation. So he has a very small stroke in the image, but very debilitating on the clinical manifestation. Maksudnya stroke tu kena kat tempat yang penting, walaupun kecil, kena kat tempat dia bercakap. Jadi dia tak boleh bercakap. So this is very important with the brain. All location in the brain are important. You pull one side, you may lose some other function. Kan elok muka macam ni, you pull one side, dia jatuh macam ni kan. Memang tak handsome. Memang tak handsome, tak ni, tak ada orang nak. So brain memang macam ni. So dealing with brain ni very interesting and tiring also. Okay, so kita thrombolize. Like I said, NIHS score dia 6. And the score dia 6. Tapi kita thrombolyze, dia cukup syarat, dia datang within time, so kita take the risk because we want to recover dia punya function at dysphasia tu. Orang tak boleh cakap ni seksa. Imagine kalau you 59 tahun, you hidup sampai 70 tahun tak boleh bercakap. Orang maki pun orang tak boleh cakap kan. People say you bad things to you pun you so mental. So very good at that point in time. This patient, despite not having a very big highway to the brain, patient improve. So improve from 6 become 2, and then 3 bulan and just score 0. Patient macam biasa. So bila kita buat angiogram juga, because patient ni bila dia improve and then kita nampak both tu macam tu, kita buat kita decide the next day because nampak dia improve macam tu. We do not touch because we dah belajar the first case. Patient with radiation vasculopathy ni kita tak perlu touch awal unless dia worsening. So kalau dia worsening in the middle of the night, we will go in at that point of time. So we were ready tapi no event. So the next day kita buat angio. Macam I tunjuk. You can see this is the MCA yang I tunjuk in the first case tadi kan, middle cerebral artery, which was not supplied by any ICA. Ni kita inject kontras ni tak pergi pun, but dia pergi through external carotid artery. Dia reflux, dia masuk external carotid artery, and you see the collateral supplying jalan yang tak sepatutnya dia supply, but which is good because dia supply the brain. Okay, dia supply the brain. So sama juga yang ni on the right side tak ada, but they get the collateral. Jalan-jalan kampung, kita orang selalu explain jalan-jalan kampung telah membantu highway tu. Hanya orang kalau jam
the
dia
busy small vessels, they are collaterals actually. So usually kalau tak ada collateral, it won't look so busy, you know. Yeah.
Sepatutnya dia bersih je jalan tu, highway je semua. Tapi sebab highway tutup, jalan-jalan kampung dekat kita punya Google Map tu pun light up. Banyak pula jalan kampung. Tu maknanya ada busy lah kat highway tu, ada jam, ada orang accident. Macam tu lah maksud angiogram. Okay. And when we do posterior circulation ni daripada belakang. So brain kita ada supply daripada kanan, kiri dan belakang. Dari 3 main supply. So yang daripada belakang, this is from tepi, you can see dia ke depan. Ni dia ke depan. From the PCOM supplying the anterior circulation. So this brain actually has been surviving with some collateral, jalan-jalan kampung daripada tepi dan daripada belakang. So they have been living with that for so long lah. Dan
what do you use to access this vessel?
This one simple je because
you use
dia hanya duduk kat bawah. We use vert catheter.
Dari mana? Dari
femoral puncture.
Femoral puncture boleh sampai.
Oh, lagi easy if you look at the trajectory, because you are going up, the femoral is easier. If you go from radial, you are going horizontal and vertical.
Yes.
So the catheter is susah.
Yes,
Walaupun you are near.
I also don't like to do radial.
So femoral lagi senang.
Yes.
Lepas tu lagi banyak boleh pakai. Okay. Alright. So, okay. Now let's talk about vaso CT. Vaso CT yang I cakap tadi lah, guna angio tapi buat gambar CT. So this is advancement of machine lah. Kalau maybe you all tak tengok di tempat you all, kalau tak ada, it's good to know. This is like macam you have AI, ChatGPT at my age lah. Kan, I can't really follow ChatGPT so much. Tapi it's something new that you must, at least you know. Okay. So, this is the image produced by the angio machine, not a CT scan, angio machine. So you imagine, we can do a CT scan like image looking at the vessels using angio machine. So patient tak payah keluar pergi CT scan. Tak payah. So on the machine itself kita boleh buat. And the good thing about cone-beam CT ni, maknanya angio machine CT ni, you can see a small vessel collaterals. So you can see the perfusion of the tissue. Small this one. This is all these lenticular striae vessels in the brain you can see from the cone-beam CT. So it provides us an information as an IR. We know how strong the collateral is. So with this kind of collateral, kita tahu we don't have to open pun the carotid ICA tu. We just have to supply with thrombolysis dulu, and the collateral is good, they can stand like that. That's why this patient dia tak ada worsening stroke macam the first patient tadi. So this is
Is
the
this
advancement in
patient's
angio.
problem related to the NPC?
At that point of time, we don't think so. We think because of he had some hypotension episode. It's a global hypotension episode. I think patient had diarrhea, if I'm not mistaken. This patient had diarrhea 6-7 times, and suddenly it become
see.
weak. So
But
we don't know why.
the thing is, in NPC also they do radiotherapy, right?
Yes. But the neck is because radiotherapy lah. Agree.
Okay.
Memang the neck he had radiotherapy, betul. Then this patient memang in the same year memang dia ada radiotherapy. That patient memang dah 15 years kan, yang first patient. Okay. So this is we minus the bone and we can see only the vessels, a very good perfusion of the brain even with collateral supply. Maknanya jalan kampung dia tu dah cukup establish macam jalan bandar. So cukup untuk supply brain dia. So kita tak touch lah. So not all patient kita kena buka saudara dia. Kalau kita buka sometimes it cause harm more than the benefit. Okay.
I see.
Alright, so this is one of the literature that we found, and this patient had this carotid artery stenosis. These two patients, we had few more patients, but this one at that time of presentation we had these two, and memang radiation can result in increased intima medial thickness, maksudnya vessels tu tebal dan menyebabkan sempit. We had 28% of them had RCA stenosis more than 30% and 13% had more than 70%. So memang ada radiation therapy to the neck memang boleh cause carotid artery stenosis. Carotid artery sangat penting sebab dia supply ke atas. Kalau you tekan ni, you punya tekak ni, you tekan kiri kanan macam ni, you akan collapse because of the supply. Okay. So kalau tengok, the radiotherapy alone actually has the highest risk of cerebrovascular event. Kalau compared to those yang ada the rest. This paper say lah. This paper say. So I'm not so sure why if you do surgery and radiotherapy it's less. Maybe because of surgery they might have a low dose radiotherapy possible, but radiotherapy alone
radiotherapy
very bad.
Yes, I have a colleague. He's also an oncologist. He passed away because when he was in his teens, he had like a thymoma, but a cancerous one, which then had to go for radiotherapy, and then eventually he had constrictive cardiomyopathy. Means that the pericardium is already so stiff, the heart cannot expand. He died from it.
Oh, it's like a tamponade,
almost like a tamponade, but like so stiff like that, and we couldn't do anything. Yes,
so,
it was very sad.
So
He's a good friend of mine.
Because we are doing radiotherapy in Beacon, so maybe it's some relevance today.
Yeah.
Okay, so turning to this case, I just want to share with you all the important, number one, the importance of the advantage of having MRI. I totally understand. Not I'm saying that every center should have MRI, but we hope probably in 5 years time, people shift from imaging CT towards imaging MRI. And not because of we want MRI, pay bagus. No, because MRI has provide a lot of information more than CT. And MRI is a technology where kalau we use more and more, it become cheaper. This is like, if you imagine you beli SIM card dulu 10 tahun lepas, 12 tahun lepas, satu SIM card 200. Imagine belum top up, 200 ada RM5 je dalam tu. But now SIM card you boleh dapat free because everybody needs to. Kalau the MRI usage is getting more and more, I believe that patient can benefit, the price become cheaper, and then we can treat better patient. Right, so we do actually basically pre and post MRI. So before stroke and day 5 post MRI, post treatment, just to see the changes. So it's good. So kalau you all have this case, advise them to go to HPUPM before hospital UPM get so busy and reject the case. Because they are growing, the hospital government will cater a lot of patients. but they try to preserve the neurovascular specialty in UPM. They can so that they can only manage that case so that they can provide a better treatment, advanced treatment. Okay, and in case of carotid artery occlusion macam tadi kan, vessel dia hilang yang nampak kronik ni, is very important to decide whether jalan-jalan kampung collaterals tu cukup tak untuk supply brain. Kalau tak cukup, then thrombectomy is needed. Kalau cukup, thrombectomy may cause harm. Sebab if you open the vessel that close, you can accidentally bring the clot up because it's already closed. So if you try to open up without weighing the risk and benefit, you can actually causing more stroke. So that's why we don't simply open a long-standing chronic closed vessels. Okay? Or ada soalan? Okay? So is this meeting for the topic? Oh, okay. Okay. All right. So thank you very much. So I hope this will enlighten and bring some apa kalau zaman sekarang orang kata belajar sesuatu daripada presentation saya malam ni. I know sometimes it looks advanced, but trust me, if you don't come to this kind of talk, you won't even learn what is advancement in radiology. Kan? Because if you rely on your day-to-day punya kerja, how would you listen to MRI kalau tempat you tak ada MRI? Kan, like me, I'm doing oncology cases all the time dekat Beacon. If I don't come to talk tentang trauma, tentang other disease, then I would not be so updated. So I hope this will add some content to you and you all feel contented with my presentation. Kalau kurang-kurang, I'm so sorry. This is the best I can do. Thank you, Dr. Betty, for inviting me. I am welcoming any question. Thank you.
Okay, come. Any questions? Okay, can you stop share for a while? Yes, because we need to share the, let me share this one. So any questions at all? I'm sharing is actually, hold on, let me share this one. Okay, share. Can you see my screen?
Oh yeah, can.
Can see? Okay, this is the QR code for doctors. So you can use your MMA app and actually scan this and get 1 CPD point. So you pun boleh buat.
I boleh juga.
Ya, you boleh juga. Okay. So kalau you nak 5 point untuk as a speaker, you give me your name, IC, MMC, telephone number and an email address nanti ya. In one message,
boleh.
I will arrange for you.
Okay.
So these are for
Okay,
the
thank you,
doctors, yeah. Any questions at all? When you
No,
do
then Fir,
the
just ask.
thrombectomy, right? When let's say not thrombectomy, like when you do angioplasty for, okay, what are the risks like?
Okay, when we dealing with stroke, the risk, what we usually, oh, they cannot see the QR code. I think you have to play the slide, I think.
Cannot see the QR code.
I think you have to.
Stop share, then I try again, huh? Okay.
So when we are doing, very good. Okay, when we are doing this thrombectomy, what we usually explain to the patient, number one, what we are so worried if, the biggest worry doing thrombectomy is, this is ischemic stroke, right? This is stroke that caused because tak ada blood datang ke brain.
Yes.
Okay, the risk of opening the vessels will cause excessive reperfusion and cause bleed lepas kita buka. This is the most important worry.
So you mean that, okay, initially is actually an ischemic stroke because there is no blood flow to the brain. But when you reopen when you reperfuse the brain, you can, where's Naim? Naim?
Oh yeah, yes,
Yeah.
I'm around.
So when you reperfuse and you open up, do an angioplasty, the reperfusion can actually convert the stroke into a bleed.
Yes, can. So that is why the theory of bleed post thrombectomy, selepas thrombect itu, we believe that the later the patient come, the higher the risk of bleed. Why? Because kalau there is more cell death dekat area brain
Okay,
tu,
the more
so
cell
the
death.
blood-brain barrier,
I see.
the
So,
higher the risk of bleed.
okay.
So
So if it's healthy tissue, it's fine. But kalau
yes,
it is infected tissue, the chances of
yes,
changing it into okay.
yes.
Dr.
That is why.
Ho asked, do you recommend a repeat CT brain if the first one is normal or request for an MRI? So
If you have,
yes, Dr. Naim is
if
trying to
you,
say it's best that you have an MRI. Go straight to an MRI, kan? That's what you're
okay,
trying to
the
say,
best,
kan? Tapi tak ada, kalau tak ada,
okay, the best situation is actually you have MR. Okay, kalau you ada CT, walaupun CT negative, you should rely on the clinical presentation. Okay, so if patient has stroke symptom, facial drop, aphasic, fast facial drop, aphasic, and then weakness, patient has stroke, regardless you see in CT or not. Okay, so more important is actually managing the patient rather than get the imaging. I am a radiologist, I love you to do imaging, I trust me, but more important is managing the patient. If it is, you must know whether it's a severe, minor, a stroke. Kalau severe stroke, you must send to the center, ataupun kalau di confirm stroke on your clinical despite normal CT, please send to the center that has a thrombolysis and thrombectomy service. You must send. They should accept. They should accept the case. Kalau dia kata I hanya accept, oh ni tak teruk sangat ni, you can lepas ni you boleh buanglah nama center tu daripada center stroke. Kalau dia hanya accept case yang susah, tapi kalau patient tu deteriorate macam mana pula kan? The reason why they have a center, such a center, is to help you all manage the stroke case. So I harap kalau from the GP side, now we are more of defensive medicine. My recommendation is you have patient stroke, you tahu you suspect stroke. That's our protocol in UPM. Patient ada suspect stroke, please send to the stroke center. Memang kita receive, I tell you, dalam satu minggu out of dapatlah 3-4 thrombectomy, but the referral 30, I tell you, 30. Semua orang datang buat MRI, which is we are okay. Kalau we don't take those cases, we won't get that 3 to 4 thrombectomy per week. So
because
the
when
staff,
we practice in this private hospital, we like, for example, the places I practice still send to UPM. They are that famous now for thrombectomy. Very famous, yes.
I tell you, we are sort of, we are indoctrinate to not reject any stroke case. Kalau kita kata, oh these people lah stroke pun tak tahu, we are taught don't say that. The reason why we are doing this and not doing other things, not doing cancer, not doing trauma, not doing other things, is to accept people's doubt. Kalau kita pilih doubt, we do not know we will talk to. Kalau dia tak tahu, you might miss a stroke. So that is why the referral for MRI is a lot. When I was leaving, I have a data of MRI brain like 756 cases in my data. So you imagine, you divide by 2 years, so almost like every day you have MRI brain. So more than one.
The treatment, other than that, also the rehab center is also very strong.
Yes.
Yeah, so they have a very strong rehab center for stroke.
Yes. UPM
Yeah.
actually tend to be a stroke hospital, I mean neuro hospital actually initially. So it was dedicated rehab. Dr. Fazura, I think, was it. So yeah, I would, although some center might scold you, please at least refer the patient.
Yes,
And kalau you nearby Klang Valley, try to talk to send to UPM. And I hope later there will be some private wing so that they can support the system. Kalau asyik government saja, I takut people are living like me.
Biasalah tu.
So supaya I harap, sebab Malaysia really need this kind of center, a very dedicated center. Kalau tak nanti dekat dengan Putrajaya, menteri je datang, VIP datang, wouldn't be fair for the patient yang tak mampu. but the aim is to treat the people kan.
Okay, I think we end here. Join us next week. You too, for a very
Sure.
interesting case, which is medical legal.
Ooh,
And
wow.
yeah, and we're going to talk about the rights of the legal rights of an unborn child. So
Ooh,
what?
who's going? Oh my God,
Yeah.
very okay.
PS Ranjan will speak, and I think it's extremely interesting. So we never thought about it before,
Yeah,
but actually
yeah.
the unborn child has rights, and what are the rights? So next week, I hope to see all of you. It's very interesting.
Okay.
Huh? Okay, see you guys.
See
Bye.
you. Thank you, Dr.
See
Betty.
you
Bye,
one
bye,
day.
everybody.
Bye. Thank you so much. I think
Bye.
it was very interesting. Bye. Bye,
Thank you.
guys.
Bye.
So